First of all, I'd like to thank everyone for inviting me to give this lecture. Roger Steinert was a close friend, and I'm going to show a few pictures of him to start out. So here is April and Roger at the RLLIC meeting that I was at when he was well, and what a special man he was. My career overlapped with him almost exactly. I started running the cornea service at the University of Minnesota when he was doing the same at Harvard, and then we both actually went off into private practice. Unlike me, he went back into academics, and I've continued on in private practice. I was honored to have him present the Innovator Award to me when I received it at ASCRS a few years back, and honored to actually give the first Steinert lecture at ASCRS, according to April. This was one of his requests, and she and I sat in the back room getting ready for this lecture, and both of us said, gee, I don't know whether we're going to be able to do this or not, but we did, and we pulled it off, and here we are at the end after she made the presentation of the medal and the plaque. So just know that Roger Steinert was a very special man to everyone, and a very special man to me. I'm going to talk about some of my thoughts on keratoconus. I will disclose that I consulted for Avedro and CXLO and Keraflow, and I do consult also for Glaukos, the current owner of Avedro. And some of the things that I'll talk about will be a little bit off-label, and not all of it is today FDA approved. So this is a nice set of slides from George Bykoff from France. Shows on your left the normal cornea progressing to ectasia with corneal thinning and some breaks in Bowman's layer, and then hydrops on the right. And really what we would like to do is make the diagnosis of keratoconus all the way to the left and then stabilize things. And as you know, today we can do that with collagen crosslinking, and that will be a big part of my discussion today. So adolescent onset, and I think that's something to remember. And one of my thoughts today is that we should be capturing young myopes when they're probably about age 6. That's about when it starts to show up for progressive myopia. And we need to follow those patients as well, because we have therapies for them. If we're carefully following that progressive myope, somewhere in the teens, probably 14 to 18, we'll likely start to see the earliest signs of keratoconus. And it's probably in that age group where we really should be treating these patients. And today, we treat most of them in the late 20s to 30s, or even sometimes 40s, after they progress significantly. The future will be follow the progressive myope, try to retard progression of myopia with appropriate therapy, and then out of that group, pick out the keratoconus patient. And then when we do recognize they have keratoconus, treat those patients. And the textbooks will tell you that the incidence is 1 in 2,000, but it's much more frequent than that. And when we look at more recent studies, we see incidence as high in Saudi Arabia here as 4.79%. A recent group of patients looked at in Denmark, 1.2%. India and Israel, 2.3%. One of the things that gives me insight into this is being a corneal refractive surgeon. And when I screen patients who are coming in for LASIK, there's at least 10% of them that make me nervous that they're at risk for ectasia. Might be a thin cornea, some inferior steepening, some evidence of a keratoconus-like form-fruste pattern. But basically, I look at it and I'm nervous, and that's really 10% of the 40% that have myopia in the USA. So it may be as many as 3 to 4% make us nervous. They don't all develop frank keratoconus, but if we're following these patients, because they pretty much all are myopes, if we start to see them progress and develop the patterns that are consistent with keratoconus, I believe that group in the future will be who we treat. Definitely, this is a combination of genes and environment. It's not just genetic, although there is definitely a genetic predisposition, and as we know, there are some dominant families that have keratoconus, but eye rubbing, allergy, atopy, environment, clearly plays a role, as do several systemic conditions that can be associated with keratoconus: vernal atopic dermatitis, Downs, floppy eyelid syndrome, mitral valve prolapse, Ehlers-Danlos, and osteogenesis imperfecta are common systemic diseases where we see an increased incidence of keratoconus. I believe in the eye rubbing theory. I believe that eye rubbing can play a role in progression of keratoconus. Some clinicians feel this is absolutely essential to counsel patients to reduce eye rubbing. And we clearly see patients with asymmetric keratoconus where they all sleep on one side, on their arm, and or have allergies where rubbing plays a role. At times we've been concerned that contact lens wear can cause progressive keratoconus. It's a form of eye rubbing, if you will, but studies do show that contact lens wear does not seem to increase keratoconus progression. So this is more of a manual eye rubbing that is an issue, and it is important, I think, for us to counsel patients when we see them to try to get them to reduce this eye rubbing and, as appropriate, treat allergic symptoms if those are causing the eye rubbing. There are many clinical signs of keratoconus, well illustrated here in B. We have both vertical stria. To the right of that, Fleischer ring, the classical Munson sign in the lower left. And then, of course, over time, these patients can develop a central corneal scarring. While we rely very heavily today on topography and tomography, before we had that, very valuable was to simply do retinoscopy. And while it's a bit of a lost skill for many ophthalmologists, you can see a scissors reflex on retinoscopy that is quite classically associated with keratoconus. And if the patient's dilated and you look again with another archaic instrument, a direct ophthalmoscope, you can often see the oil droplet reflex and categorize actually these cones into central round type cones, oval cones, and then the inferior sagging cones that we see with pellucid. The other early finding with classical instruments is what we call tilting of the Myers on keratometry. And with a classical Bausch and Lomb keratometer, if the Myers, the plus Myers, don't line up, that's another classical finding of early keratoconus. And sometimes on the earliest cases, I'll actually take a look at both retinoscopy and standard keratometry. These patients do develop increasing astigmatism and, while not 100%, mostly progressive myopia, and of course loss of uncorrected and best corrected acuity. The critical test today is both pachymetry and topography. And refraction is important as well too, because the FDA approval in the US requires us to document that the patient is progressing. And fortunately, the definition of progression is relatively low, which is simply a half a diopter of progression. This will be an interesting challenge when we start to capture all the young myopes in our practice, because they're going to be progressing as well. And collagen crosslinking will not likely be the ideal treatment for most progressive myopes until they develop signs of keratoconus as well. But it will be quite easy, I think, to document that they're progressing. And that is best done, as in my experience, with refraction. So, as we know, and I mentioned already, despite advances in diagnostic tools, we're not catching these patients as early as we will. And most of them are not diagnosed in their teens. And most of these patients do develop keratoconus at that early stage. We need to start to catch these patients early so we can actually retain relatively normal function and no loss of uncorrected and best corrected acuity. And if they're under 40, they're almost always progressive. And while we need to be able to document in our charts that they progress to half a diopter, we can do that by getting previous refractions or previous topography or keratometry. But the easiest, again, at least for me, is progression in refraction. And this can progress rapidly, and that's one of the reasons why I'm not a big advocate of simply telling a patient, for example, come back in 6 months, or worse than that, come back in a year, and let's see how much you progressed, because many of these younger patients can progress more than a diopter over a 6-month period. And we don't want that to happen, as well as the development of increasing coma and irregular astigmatism. So once we start to worry about keratoconus, simply look at prior refractions, and you'll almost always be able to document that the patients had progression. I kind of like this slide. Theo Seiler was another close friend. He's an MD, PhD, originally from Germany, and then moved his practice to Switzerland. But he claims he got the insight into using crosslinking at the dentist's office, where crosslinking is used actually to treat gum disease and gingivitis. And the thing I like about this is that another good friend of mine, Charles Kelman, claims he got the idea for phacoemulsification in the dentist's office as well, and that in his book he claims, and talking to him personally, that he jumped up and left the dentist's office in the middle of having his teeth cleaned with an ultrasonic device and ran back to his laboratory to begin to look at the idea of ultrasound for removing the natural lens. So two things clearly very important in my practice: one, phacoemulsification, and the other, collagen crosslinking. Both the light bulb went off in brilliant prepared minds while they're in the dentist chair. I think that's quite interesting. The key issues in crosslinking is we need ultraviolet light, we need a photosensitizer, and then we need oxygen. Oxygen is the one that's often forgotten. And as we progress in our understanding about keratoconus, we're learning, for example, that intermittent delivery of UV light is probably better than continuous delivery, because continuous delivery depletes the oxygen, and then the cross-linking process stops. Our photosensitizer is a vitamin, riboflavin, as we'll talk about. So relatively available parameters here to do a cross-linking job. And our dermatologist friends were actually into this well before we were, as were our dental friends. But we've learned from them and learned how to stiffen the cornea, increase Young's modulus through the use of collagen crosslinking using ultraviolet light, riboflavin, and the natural oxygen or supplemented oxygen that's available in the atmosphere. Now, it's always good to remember that crosslinking actually occurs just naturally. Just like all the other collagen in our body, it stiffens over time, and this shows Young's modulus against donor age and donor corneas, and you can see increasing stiffness progressing from age 25 up to over 100. And this is why, as patients get over 40, many of them naturally cross-link to the point where they're not likely to progress. So again, as we see older patients, then that group of patients, I'm willing to say, come on back in 3 months or 6 months, and we'll repeat your topography and refraction. And maybe you won't have to be cross-linked, but if you do show progression, then you will. And I have had to cross-link some patients even in the 60s and 70s. Now, the original Dresden studies that were published in the Journal of Cataract and Refractive Surgery way back in 2008, they had 241 eyes and 130 patients that they studied. And if you look at the graphs over here, we've learned, even though it's not ideal, to kind of look at Kmax over time. And if you take a look here, you see that while there's reducing follow-up with time, there is a progressive, if I get my pointer here, progressive flattening of the cornea that occurs, in this case, out to about 4 years. And then ends of only 5 and 4 probably aren't enough to matter, but we're seeing a progressive flattening with the original Dresden approach, and realize these were relatively steep corneas with Kmax of 63. And the typical patient that wasn't treated is progressing in the range of a half to 1 diopter a year. So meaningful improvement by a year, but increasing flattening out to 4 or so years. And I think that's another thing that's important for us to remember, especially if we're going to apply other surgical procedures like PRK or PTK is that the flattening will continue for 3 to 4 years, and we need to plan that into what we're doing. Now, there's no doubt that collagen crosslinking is having an impact on corneal transplantation. One of the best registries in the world in most areas is in the Nordic countries, and this is an example of Norway, which showed between 2006 and 2013 a 53% reduction in corneal transplantation as collagen crosslinking increased. And I think the goal for the next generation for the residents and fellows in the audience is that we would like the incidence of corneal transplantation for keratoconus to go to 0. I think this is a disease as far as corneal transplantation requirement in the advanced countries that can more or less be eradicated if we treat it properly. Well, the first studies brought into the US, which was actually Peschke, and we were part of that clinical trial at Minnesota Eye Consultants. Unfortunately, we didn't follow the patients long enough, and we had a crossover clinical trial design. Another interesting finding is to design your trials properly. The bottom line is we didn't follow the patients long enough, so we didn't achieve the FDA required goal, which was to show a diopter improvement in the treated versus the non-treated group. And so then further studies needed to be done. And that's why it took so long to get things approved in the United States. We also worked with Topcon early on, and then finally worked with Avedro with the classical Dresden epithelium off approach. And these trials included 205 patients with progressive keratoconus and 179 with corneal ectasia following refractive surgery, and they were followed for 12 months. And as I'll show you here, 12 months was plenty long enough to see a difference. If we take a look at the two studies done, in one, the cornea flattened 1.4 diopters, and the other 1.7 diopters at month 12, while in one, the Kmax increased a half a diopter and the other 0.6. And so these keratoconus patients showed progression of a half a diopter at a year, and then they showed corneal flattening of about a diopter and a half at a year. And that was a 2 diopter difference. What the FDA wanted was at least 1 diopter, and so that was approvable with 2 separate studies. In the corneal ectasia group, there was slightly greater steepening, about a diopter, and slightly less flattening, about a diopter. But again, the delta between the two was about 2 diopters in 2 separate studies. And so we were able to achieve approval both for corneal ectasia following refractive surgery and for keratoconus. And they followed each other fairly quickly, April 2016 for progressive keratoconus and July 2016 for corneal ectasia following refractive surgery. And around the world, the consensus really is that anyone with progressive corneal ectasia should undergo collagen crosslinking no matter what age or level of vision. That's the global consensus, and I agree with that consensus. The one thing that we're not doing well enough is we're not diagnosing the patient with progressive ectasia at a young enough age. We don't want to stabilize patients with Ks in the 50s. We want to stabilize patients with Ks in the 40s and just the earliest signs of keratoconus. And if we occasionally treat a progressive myope that might not have developed clinically significant keratoconus, to me, I think that would be okay, because we're going to flatten their cornea a little bit over time. If anything, we're going to help them. And as I'll show you with our more advanced techniques to collagen crosslinking, the risks are relatively low. So early intervention is critical, and to get that done, as I said, we need to capture the progressive myopes from age 6. They're probably going to continue to progress to 26, and somewhere around halfway in between, around 16 to 18, the ones that need treatment for ectasia will start to show up. Now, the classic Avedro, currently FDA approved, and Dresden approach, you remove the 9mm central epithelium, apply topical riboflavin, check for saturation of the cornea and flare in the anterior chamber, check their pachymetry. If it's less than 400, you use hypotonic drops to thicken it to 400, or you do not treat according to the FDA approval. for safety to the endothelium issues. And then you apply 30 minutes of continuous UV exposure at 3 milliwatts per centimeter squared at 365 nanometers. So we've learned some things here, and I'm going to talk about that as we go forward, as to maybe this isn't the ideal and best way to treat keratoconus, but it is the FDA-approved way to treat keratoconus, and it certainly is very effective. The primary issue in postoperative care is something quite familiar to us if we're corneal refractive surgeons, is getting the epithelium to heal, and we want that epithelium to heal in a week or less, and if not, we need to intervene and do whatever it takes to get that epithelium to heal. We need to counsel patients that initially their cornea steepens a little bit because the compensatory central epithelial hypoplasia is removed when we scrape off the epithelium, but that by a year they're likely to experience some mild flattening. But I never promise patients that will necessarily reduce their myopia, because we don't always. The goal is actually to simply stabilize the cornea. Most of these patients develop reticular haze of the cornea. When they have epithelium off, it tends to fade with time. We tend to treat these patients as we would a PRK with a tapering steroid dose, where we usually start with 4 times a day for 3 to 4 weeks, and then 3, 2, 1, and cover with an antibiotic until things are well healed. It is a painful procedure, and so we use a short course of NSAIDs, a bandage contact lens, and in many patients will require some mild opioids. So one of the things that we wanted to do early on was to see whether we could develop an effective technique to crosslink the cornea without having to remove the corneal epithelium. And I got involved early on with a group called CXL USA, which was a clinical trial. I believe there were 18 of us that were involved. Doyle Stulting and Bill Trattler have published some of these results. And we did a surface treatment to allow the riboflavin to enter the stroma, and we used 12 millimeter diameter light, no UV, no riboflavin during UV exposure, and then instead of continuous light application with the ultraviolet, we did pulsed, and that's because we wanted to eliminate that oxygen loss that occurs with continuous exposure and a slightly greater fluence of UV light, 4 milliwatt per centimeter squared. If you take a look at the data in this group of patients that were followed carefully by Doyle Stulting, he removed the contact lenses in every visit, etc. 295 eyes followed out to 12 months, and notice that Kmax only flattens here about 0.44 diopters from 56.14 to 55.71. As we mentioned, we're going to have about a half a diopter increase in steepening, and here we're getting about a 0.44 diopter flattening. And for FDA approval, we're going to have a diopter delta, and so this is right on the edge of being good enough to achieve that. And one of the criticisms of epithelium on is that it's not as effective as epithelium off, and I think the data definitely does confirm that that's true. But we had quite excellent results while in the CXL USA study, and our need for retreatments was less than 1%, and that was true of the other centers as well. So this was really quite promising data, but this has not yet entered phase 3 clinical trial, only a phase 2 clinical trial. We made some modifications here that we use in select patients at Minnesota Eye. We call it the Minnesota Eye cross-linking approach. It's off-label. Again, we do an application of riboflavin to the stroma with epithelium on, and I'll show you how we do that. We've increased the concentration of the riboflavin to 5 milligram per ml, and actually put tetracaine anesthetic in it, which also tends to break down the tight junctions between the epithelial cells. It takes about 20 minutes to saturate the cornea, and we do intermittent light on, light off with artificial tears, and that makes the patient a lot more comfortable after the surgery. So here's the approach. We simply put topical anesthetic in the eye. This little device is called Keraflow. It's a modification of the Morgan lens, and then we massage the epithelium slightly with the with the Muracell sponge that's on the inside of the contact lens. That removes the mucus, and the higher concentration of riboflavin and anesthetic enhances penetration. We do very frequently bilateral same day, while in this patient we're doing a single eye, do them at the same time, and then you can apply the UV light in both eyes intermittently. So this has been an attractive option for our patients. This is a group of 324 eyes that we've followed with 183 out of 12 months, so some loss of follow-up. But in this setting, we're able to double the corneal flattening that we were able to achieve in the CXL USA study. So we're getting minus 0.89 diopters of flattening in Kmax, and the average patient steepening a half a diopter. This would allow us, with this type of an outcome in a proper cohort and 2 studies, to achieve FDA approval. But we're quite comfortable with this approach. It's our favorite approach when we're allowed to do it based on insurance coverage and the like. We also apply Intacs quite frequently, and I want to talk a little bit about how we do that in our patients and why we do it. And Intacs have been around for a long time. They're 150-degree arcs of PMMA, inner diameter 6.8, outer diameter 8.1. They were originally brought to market by Keravision to treat myopia, and that's what they do well. They were sort of dead on arrival because the eczema laser got approval about the same time. It was thought, and I was an investigator, that this might replace incisional refractive surgery like radial keratotomy, but eczema laser turned out to be much better. So it never really had a role to play in the treatment of myopia. But what it does basically is just mechanically stretch the cornea and flatten the cornea centrally. And it was approved for myopia back in 1999. And then in 2004, we got the ability to use it in keratoconus patients. But it does require a special IRB approval. So it's still kind of a clinical trial. Every year you have to report your outcomes. It's never achieved FDA approval specifically with a keratoconus label, but it is followed by the FDA, and you are allowed to utilize this sort of on label with IRB approval. Now, classically, you place 2 Intacs, but we've found that a single Intac placed according to a mire shined on the cornea, what I call intelligent placement. So we'll make the channel, and then we'll rotate the Intac to the ideal position to round the mire. And I do these actually on the Visex laser that has a round keratometric mire, although you can also get that with an operating microscope. You can kind of rotate this Intac to the ideal position, simply putting a single one in. You do not need to suture the incision, and the recovery time is relatively rapid. With Intacs, you achieve about a 3 diopter flattening of the cornea. And so if you want to flatten the cornea, if you want to reduce the patient's myopia, and I'll show a case example of a patient I wanted to do that on, this is effective. And it turns out that you can combine Intacs along with collagen crosslinking, and you can combine Intacs along with collagen crosslinking, and then later do either a topographic guided or wavefront, a PRK or PTK or ICL or refractive lens exchange, any of the above. Now, a few things we've learned is that Intac plus crosslinking decreases myopia and astigmatism more than collagen crosslinking alone. So if you want to flatten the cornea about 3 diopters, and then rather than 1 to 2 diopters, then think about using an Intac. You can do them in any order, but Intac first followed by collagen crosslinking, according to most experts, and I'm included in that, is better. You can do single or paired Intacs, and these are currently sold by CorneaGen. And if you send your topography, they'll tell you what they recommend. But in my experience, a single Intac works as well as a pair, and in some series, a single was actually superior. So I never do more than 1. And then in select patients, you can let things heal a year or more after Intac and collagen crosslinking, and then do a PRK or PTK over it. And that allows you sometimes to really get some amazing outcomes. And very occasionally we've used conductive keratoplasty, another FDA approved treatment off-label to reduce astigmatism. So in closing here, I'm just going to give you an example of what you can do with what I call refractive crosslinking. You know, therapeutic crosslinking, we simply crosslink the patient, try to stabilize the situation. Refractive crosslinking, we try to improve the patient's refractive outcome as we would with refractive surgery. So this was a professional athlete who presented to me, and in his right eye was minus 2.25 plus 1.25, refracted at 20/25, uncorrected 20/70. In the left eye, he was much more myopic with more astigmatism, refracted only to 20/50 and 2200 without correction. And he was contact lens intolerant for his profession and did definitely have progressive keratoconus, 26-year-old professional athlete. So when I'm thinking about the plan here, when I'm looking at the right eye, I would be happy just stabilizing this. And I didn't really feel like that was a severe refractive error, so I didn't feel like I needed to do an Intac in that eye. But in this eye, you know, the anisometropia was definitely an issue. It was contact lens intolerant, so I recommended that we place a single Intac in this left eye and then follow with collagen crosslinking. And when I have a case like this, I'll do the Intac and then I'll let things heal for a month and then I'll schedule the crosslinking a year later. So let me just show you how things worked out in the two eyes. So let me go back one. So in the right eye, you know, with the progressive keratoconus, you know, just after the epithelium on crosslinking, we did improve his vision some, but we then, at 18 months after surgery, went on and did a PTK, but using a PRK card, treating his refractive error, and we were able to actually come out with 20/20 corrected, 20/20 minus 3 uncorrected, a pretty, you know, remarkable outcome for this young athlete. In his left eye, the single Intac flattened his cornea, and so he improved from minus 350 plus 350, excuse me, minus 575 plus 350, down to minus 350 plus 1.5, a meaningful improvement. But in that eye as well, I did PRK, PTK, and he improved there to minus 3/4 plus 1/2, 20/20 minus 3. And his uncorrected vision was 20/25. He could play professional football in this case without contact lenses or glasses, and actually went on to become an all-pro selection. And so we're definitely making advances in our ability to help these patients. As I mentioned at the beginning, the ideal thing will be to prevent them from ever having a problem. But of course, today we see many patients with advanced disease, and we do have advanced transepithelial techniques. We participated in the Vidro Epion technique, which also adds oxygen being applied in a high concentration, and so and intermittent treatment. I think that will be FDA approvable and be coming along. We have the ability to combine other refractive procedures with collagen crosslinking. Realize that these are all FDA approved procedures, but their combination with crosslinking is definitely off-label, but we're allowed to do that as practitioners. And over time, we might find other applications for crosslinking as well, such as the treatment of low myopia or even early progressive presbyopia with selective collagen crosslinking. So we're going to see a lot more innovation in this area, and likely it will increase because of investment from Glaukos and Vidro going forward. So as Yogi Berra said, predicting the future is easy, being right is hard. I always say that you know, perhaps a third of what I just said will turn out not to be true, and unfortunately I don't know which third, but the information I give you today is what I believe today to be appropriate and accurate. And thanks again for this special honor. This is actually my second Steinert lecture, one at ASCRS and one at Gavin Herbert. And I love Gavin Herbert Eye Institute. It's my second home. I live in the winter months about 2 weeks a month just up the street on Ridgeline Drive, right across from UC Irvine. And I've had the opportunity to come over and visit with many of you at least a couple times a year at Gavin Herbert. So Roger Steinert, very special to me, and April Steinert as well, and Gavin Herbert also very special to me. And thanks again for this special honor.